Welcome to Doc Talk, a weekly podcast featuring Monument Health physicians addressing medical topics. Tune into your health with Monument Health. It's another edition of Doc Talk. I'm Leslie Hopton, and in studio today I have Dr. Fernandez and I have Jessica Hutchinson, who is a certified nurse practitioner. And together you've come in today to talk about something that maybe in the media it's made fun of, or maybe we know someone who deals with this, maybe you do, restless leg syndrome. So first and foremost, welcome into the studio, and let's start with the basics. What is restless leg syndrome?
Well, thank you for welcoming.
Yeah, thanks for having us.
Yes.
Yeah.
So I've been telling Dr. Fernandez for a while we should talk on restless leg syndrome because it's a really frustrating thing that we work with in sleep medicine, and there's been some changes to the guidelines that aren't well known. So to start, restless leg syndrome is sensory motor movement related disorder, and the diagnosis relies on clinical symptoms.
Mm-hmm. Yeah, so the International Classification of Sleep Disorders, ICSD, which is our manual to diagnose sleep problems, states that restless legs is one of the motor sleep-related disorders. It is the most common motor sleep-related disorder, and people need to meet certain criteria in order to qualify for that diagnosis. And like Jessica was mentioning, it's a clinical diagnosis, so we don't need any further testing to make the diagnosis. However, we may in order to treat our patient. Okay. So the diagnostic criteria includes an uncomfortable sensation down our legs whenever we are either about to fall asleep or we wake up in the middle of the night, or we are sitting for prolonged periods of time. And if you could see me, I'm moving my legs right now because I do have restless leg syndrome.
Okay.
So this sensation is not secondary to any other health condition, such as obstructive sleep apnea. Hence, we need to make kind of like the clarification whenever we are reviewing a sleep study or whenever we're seeing the patient is either, do you have this sensation down your legs, creepy crawlies, like pain, an urge to move your legs? Is that urge getting better once you move your legs? If it does, that's another clinical clue. The other thing is like, do you feel like it's following a circadian pattern? Mm-hmm. Hence, whenever we're sitting around or in the evenings. And if the patient meets that criteria and they are experiencing these symptoms for at least 2 to 3 times per week, then we can call that restless leg syndrome.
So those would be the big signs of restless leg syndrome, because we've all had restless nights, but it's a little bit different. It goes beyond that, right?
Correct, yes.
Okay. And then if you're still trying to classify, is this restless leg syndrome, and you go in to see you guys, how do you help classify that from just like regular muscle tiredness? Maybe you're going through a period of anxiety. How do you walk your patients through that process?
That's a great question. I think for me personally, I tend to find that circadian rhythmicity to it. That's one. Usually if you are tired or if your muscles are sore, you'll be sore kind of like throughout the day or in that 24-hour period. There is a chance that after a massage you may feel somewhat better. But this is more so like this uncontrollable need to move your legs.
Gotcha.
And like Jessica was mentioning earlier, it's a sensory motor problem. So you have that uncomfortable sensation, but relief by movement. So I think kind of asking very incisive questions at times can be helpful.
Mm-hmm.
How do you approach it, Jess?
Well, and I'll hear patients describe it as like bugs in their veins or Rice Krispies. They say it feels like the way Rice Krispies sound is the way it feels in their legs. So really trying to distinguish it from just is this leg cramps or neuropathy.
Yeah, it can be challenging at times. And so other things that I do too, and I think most of us in the sleep center do, is we try to look for some answers. We check the patient's medication list. Are you taking medications that are more activating from a motor perspective? Are you getting enough sleep? Are you drinking copious amounts of caffeine or energy drinks? because you'll move, and that is just a basic response to those substances. The other thing that I look into, and all of us do, is check the patient's iron levels, because restless leg syndrome it has a genetic component, particularly when it's secondary to iron deficiency. It can be secondary to dopamine dysregulation, or again, secondary to other concomitant sleep disorders, including obstructive sleep apnea. So if you're seeing the patient for the first time, there's a chance the patient may have some type of sleep disorder breathing. So you try to address that. If you do the sleep study and you find that they're moving their legs, okay, the diagnosis is potentially still restless legs, because you already asked those questions and it follows that circadian rhythm, but there is a chance you don't need to treat it with medications or supplements if there is resolution of the restless legs once we address the other sleep disorder. However, if you still see that persistence in the patient's restless legs after you address their other sleep problem, you again go back and evaluate. How are these patients' iron levels? Are they adequate? Are they appropriate? And we have a different threshold and cutoff than what it's considered to be normal for the general population. And if that is okay too, then we move forward and assume it may be secondary to dopamine dysregulation. And then we talk about actual medications for restless legs. Something that I wanted to mention is that we're talking about restless legs in adults. In children, it's more of a challenge to distinguish their symptoms. They usually ask their parents to please rub their legs at night, or they feel like, I just want to kick. Yeah. So if parents hear that complaint, or they see their child somewhat restless on a car ride and they're just kicking or moving their legs, there is a chance they may have restless legs. So I would highly advise all the parents out there to please talk about that with their pediatrician, or just come to the sleep clinic.
It sounds like, as with everything with the human body, it's very interconnected. So it seems like part of that process is, making sure, is that a secondary effect of, like you said, sleep apnea or some other sleep disorder. But if someone's dealing with restless leg syndrome, what are some of the other ramifications? Obviously, you can't sleep as peacefully as you normally would, but what else are you seeing in your patients that come in to see you that you're like, if we resolve or help control your restless leg, you will see benefits in these other areas as well?
So I guess I would say the interrupted sleep is probably one of the biggest things. The people maybe we've treated their sleep apnea and they're still just excessively sleepy.
Yes, that is one of the most common causes of excessive daytime sleepiness after having adequately treated obstructive sleep apnea. Because of that sleep fragmentation Jessica was mentioning, and you can see it pretty clearly when you do their sleep study. The other consequence of having untreated restless leg syndrome comes from a cardiovascular perspective, because fragmented sleep would lead to cardiovascular consequences such as high blood pressure, some types of arrhythmias.
And no one wants to hear that, right?
Right. And in children in particular, it has been associated with ADHD. There's a bidirectional relationship between restless leg syndrome and ADHD. So you're more successful, or you would be in a better position to address the patient's ADHD if you also treat their restless legs, and the opposite is true too.
Right. And is this something that, when you're trying to diagnose, trying to see what else is going on in the bigger picture of your patient, is this something that the patients always come in for a sleep study, or how often would someone go in for a sleep study?
I would say most of the time we do need a sleep study. It's just pretty challenging to diagnose a patient with any other type of sleep disorder until we rule out sleep disorder breathing. And for that, we would need a sleep study to actually acquire that data. However, sometimes we may feel comfortable moving forward with a home sleep study versus an in-lab sleep study. Oh, wow. It would always depend on the patient's clinical presentation, of other health conditions they may be dealing with, or the types of medications they are taking at that time that would predispose them to other pathologies or health conditions. But yes, usually we do sleep studies rather often just to ensure that's not the main problem. I know this is a little bit off topic, but I like to think about sleep disorder breathing as syphilis. which in medical school, syphilis can mimic every other health condition.
Right.
So when you think about sleep apnea in that way, you're like, okay, I really need to pay attention to this, ensure my patient doesn't have any type of sleep disorder breathing, and then I can move forward with treating whatever else there is, whether that's insomnia, restless legs, or any excessive daytime sleepiness.
Right, because the effects of that, I'm assuming, follow us after we get out of bed, right? It might be
Correct.
a mood disorder, or we might have anxiety, or just really, really sleepy throughout the day beyond
Yes.
what's normal for every day.
Yes.
So then once you do diagnose, let's talk about treatment. It seems like it's a combination, medication, but also maybe lifestyle changes. Well, what is that conversation like?
So the first thing is, like Dr. Fernandez mentioned, is we always check iron levels. Restless leg syndrome is often iron deficiency of the brain, and so we want to make sure that we're not missing that. So we'll usually get a fasting iron panel. We want to look at not just ferritin, because that's an acute phase reactant, but we also check iron and total iron binding capacity. And if their iron to total iron binding capacity ratio is less than 20%, we do give them iron supplement. And then this is the big thing that has changed in the guidelines, is in the past, our first line treatment for restless leg syndrome was our
Dopamine agonists.
our dopamine agonists. So that would be our pramipexole and ropinirole. And in more recent time, they're finding that over time, these are causing augmentation. So augmentation is a gradual worsening of the restless leg syndrome symptoms in intensity and duration over the longer you've been on it.
Okay. Could you, for the everyday person like me, could you talk about the relationship between dopamine and restless leg syndrome?
Yeah, so dopamine, and that's a pretty great question. Okay, so we have certain neurotransmitters that are promoting wakefulness. That would include acetylcholine, serotonin, norepinephrine, dopamine, histamine, orexin. And dopamine plays a significant role in restless legs because even though we don't fully understand the mechanism, we know there is a dysregulation in our dopamine. And that may be secondary to the fact that we are probably missing some of that iron, because you need iron to form dopamine whenever we are talking about, biochemistry and all of those chemical structures.
Yeah.
So if you have a dopamine dysregulation, meaning that you would have enough or adequate amount of dopamine in your system, however, not appropriately perceived by your body, then these medications, the dopamine agonists, were effective in helping patients control their need to move their legs.
Gotcha.
However, over time, we've noticed that the patients needed a higher dose of that dopaminergic medication. And eventually, like Jess was explaining, they would experience worsening symptoms, meaning their symptoms would start earlier in the day. They were just probably getting restless leg syndrome in the evenings because of how the disease works or the health condition works. But now they are experiencing restless leg symptoms at noon. Hence, I need to take more doses of my medication, and maybe that's not enough now. I need to take higher doses of that medication too, and the problem just keeps getting worse over time. The other problem with the dopamine agonist medications is that we saw a lot of impulse control behaviors or problems. This is from my clinical experience, I've had patients that gambled their homes, their houses, everything they owned. And this is not necessarily here in town, this is in the East Coast. I've had patients that have lost their partners because of that sense of impulsivity. Hypersexuality is one of the complaints people come into, like, I am finding myself, involving other extramarital relationships,
Right.
just because of, and I don't know what's going on. And when we talk about things and we try to find what has changed, it's the medication. You taper the patient off the medication, which is pretty challenging, and then we start noticing some improvement.
Okay.
But yes, augmentation is a big problem, but like Jessica was mentioning before, that used to be the first treatment modality. In recent years, I believe since 2022, 2023, the guidelines have changed, and officially this year in January, I think it's when they released the written guidelines. That is no longer our clinical practice parameters. We check, like Jessica was explaining, ferritin, iron first, and then we move on to think about other things, including the role of dopamine agonists.
Okay. And then in a bigger picture, what would you tell your patient, while you're trying different methods? Are there lifestyle changes that you encourage them to make as well, that you've seen firsthand improvements in their condition?
Yes.
So I think that regular exercise can be helpful. Having routine activity, having a routine bedtime schedule, avoiding things like alcohol in the evenings. Caffeine can exacerbate symptoms. Massage can be helpful. Warm baths and warm showers can help alleviate symptoms. And then other exacerbating factors would be like diphenhydramine. Are they taking Tylenol PM? And the diphenhydramine is well known to exacerbate those symptoms.
Yeah. And I think that's a pretty important point, because oftentimes, due to the restless leg syndromes, the patients may experience a lot of, like Jess was mentioning before, sleep fragmentation, and they start to look for sleep aids over the counter. And most of them contain some form of an antihistamine medication, especially the first generation ones, which do cross the blood-brain barrier. And with that, we see that sedative effect, which is what the patient is looking for. But at the same time, they promote more restless legs. So if you have restless leg syndrome, I think it would be ideal to stay away from anything that says PM.
Yes, and I could see how it would be, I'm not going to say tempting, but you would reach for that, right? Because we're also talking about something I would say is pretty emotional. Everyone needs to sleep, right? There are only a few things that all of us need every single day, and sleep is one of those things. Could you touch on maybe the emotional side that you've seen from your patients as well? You want to go to sleep, but your legs have other plans, and that causes that fractured sleep. And what have you guys seen?
Boy, I've seen patients who have developed augmentation, and we're trying to wean them off their agents, and it's really, really significant. I've heard people use the words that it makes them homicidal or suicidal because of how severe those symptoms are, and that they're not just at night anymore, they're experiencing them during the day. So really, really important that we manage those symptoms well.
And I've had the same experiences, especially with refractory restless leg syndrome, meaning that it doesn't necessarily respond to the first treatment options you're trying to implement with the patient. And like Jess was saying, I've had patients that are struggling with depression. I have had patients that are in a, mental state where they don't feel they want to keep being on earth just because of how challenging it is to deal with this health condition. However, oftentimes, the patients that end up having refractory RLS or restless leg syndrome, it's because they do have an underlying sleep-breathing disorder that is not being adequately addressed. Therefore, even though you use all the right medications, until you tackle that portion of the equation, we would still struggle with that. So it can be quite challenging mentally, physically, emotionally, not only for the patient, but for the patient's family too. It's very sad to see your partner, your loved one struggling. And obviously, people that are in pain or people that are struggling with a health condition that is not necessarily noticeable to the naked eye undergo a lot of emotional and mental hurdles. And even though their partners or loved ones they may want to be empathetic, at times that takes a toll on them as an individual, and their expression of that frustration may be, with their relatives. Yeah. And so it can really fracture their personal relationships too. So there's a lot of potential ramifications to untreated or inadequately treated restless leg syndrome.
I could see that. And I mean, we have all talked about, someone snoring, or we see more commercials for if you're snoring or you have sleep apnea, but maybe RLS is one of those things that's not as commonly discussed, but it's very common. I'm not going to say it's normal, but it's common. And if someone's listening right now and they're realizing, they're putting the pieces together, this is what I'm dealing with, what advice do you have for them? What are the first steps that you're offering them?
Talk to your doctor.
Yes, I would say that. I agree. Talk to your healthcare provider. Please do not let them put you on a dopamine agonist, aka ropinirole, pramipexole as a first-line agent. Make sure they check your ferritin levels. Make sure that when your doctor ordered that blood test, you are in a fasting state. Make sure you have avoided red meat products for at least 24 hours prior to that blood draw. And something that Jessica always does is that she asks the patients to hold their iron supplements for at least 3 days. That's what she has said. So
yeah, it's good to know. These are the tools that we need when we come in to see you guys. We don't have the same, language and tools that you do. So, any help is helpful when you're dealing with something like this.
Yes.
Yeah.
And we do have a newer treatment modality for restless leg syndrome, which is called a bilateral peroneal nerve stimulator. It's a new treatment modality for selected patients. There's a list of contraindications. However, talk about it with your doctor. If you choose not to follow or pursue a pharmacological option, then we can talk about that nerve stimulator. And it's nothing implanted in your body, something you will take off every day. So no surgery or downtime needed.
That's perfect. There is hope.
Yes.
Not to sound dramatic, but there are other pathways, and I think it's incredible to hear that even just in the past few years, more pathways have opened, and the ongoing research gives people hope. So thank you so much, Jessica, Dr. Fernandez, for coming in, talking about restless leg syndrome, and hopefully someone's out there listening right now, and maybe you'll see them in your office later.
We look forward to see them if needed.
Thank you.
Thank you.
Thank you.